Hi everyone, welcome back to the channel. Today we'll be talking about bradycardia. This will be a simple and practical ward-based approach to bradycardia. So it's not a video in which we are going down to the basic medical sciences, but rather what you should do and what you should know how to do in the ward settings, especially when you're going for an internal medicine rotation. Now, if you enjoy the video, please consider giving a thumbs up or consider subscribing for more content in the future. If you have any comments to make as to how I can improve on my videos, please feel free to leave a comment as well. Now, without further ado, let's go into the video. So, bradycardia, first of all, is not a diagnosis. It also does not tell us what the underlying problem that's potentially causing the bradycardia is, nor the underlying rhythm abnormality that could be potentially associated with the bradycardia, such as a heart block. More on that later. So, a common scenario in which you'll be called in the hospital settings to see a patient with bradycardia is simply when a nursing staff does their routine OBS and be alerted to the potentially new bradycardia. So a common scenario is going to be, hey doctor, the patient has a heart rate of 50, have a look at the patient. Now, let's go down to our approach. So first of all, whenever you see a patient in the hospital settings, always do a quick ABCDs, and this can be done quickly in your head. So airways, breathing, circulation, and disability as the main point of any junior doctor in the hospital is to make sure that the patient is safe and alive and kicking. So safety is the first thing. Anyways, so you can quickly tell that A and B is probably going to be normal, given that the nurses haven't called you to a med call or a code blue, and we already know that the heart rate is going to be less than 60 in C. Now, at this time, if the patient does not have IVC put in, you may want to consider that, because any patient who's getting intravenous drugs should have an IVC, and any patient that could potentially be unstable that you're not sure of as a junior medical staff should potentially have an IVC as well, as you do not want to have difficulty putting one in a rush in a med call situation or code blue situation. Now, it's important at this time to let the nurse to do the other OBS, even though they will be pretty on top of things. So get them to do the other OBS and an ECG. During this time, if you do not know the patient, have a look at their inpatient charts and folder. What they come in for, what is their presenting complaint, and at the same time, what are their current inpatient issues. The reason why it's important to get OBS, presenting complaint, and issues at the start is that they can potentially help to narrow down the underlying issue, and they can potentially alert you to things that are potentially life-threatening. Just an example, if a patient has got hypertension on top of the bradycardia, and should their presenting complaint be an ischemic stroke, you might be thinking now, but don't worry if you're not. It takes time that potentially the patient has got raised ICP from a hemorrhagic transformation of the ischemic stroke. As I've alluded to, without knowing the presenting complaint, which is ischemic stroke, we wouldn't be thinking of a raised ICP in just anyone with hypertension and bradycardia, since many inpatients are hypertensive anyways. So it's important to tie them down together to help you with your patient management. Now, whilst the nurse is finishing up with the OBS and the ECG, you can ask the patient about their symptoms. And that is pretty important as well, because symptoms just adds extra information and should always be part of a clinical assessment that will help you to narrow down your diagnosis. So, important questions to ask about symptoms is evidence of hemodynamic compromise. And this can include syncope, pre-syncope, chest pain, shortness of breath, etc. Because the thing is that if a patient is symptomatic and they are bradycardic, you may be more inclined to think that potentially by reversing the bradycardia that's new, their symptoms could potentially resolve and that their symptoms are simply due to the bradycardia. A clinical pearl at this stage would be that in their file, you should look for evidence of a previous echocardiogram. So it's transthoracic TT and transesophageal echocardiogram. The reason why this is so is because you want to know what their so-called baseline ejection fraction is. Because if they have a low ejection fraction and now there's a new bradycardia, they're more likely to be symptomatic or they're more likely to become symptomatic and potentially hemodynamically compromised should the bradycardia persist. Now, it may be very reasonable to not initiate treatment if the patient is asymptomatic, which I will briefly touch on later. Now, have a look at the ECG, as the nurse would probably be done with the ECG by now. If they're in sinus bradycardia, that's often fine because it's very common and very normal for someone to be in sinus brady just due to increased vagal tone, especially in young, healthy athletes. So if the patient is young, then sinus brady is probably not going to be an issue anyway. And also it's important to note that it's very common for people to be in sinus brady whilst they're asleep due to an increase in vagal tone. Now, other abnormalities to look out for that are common would be an atrioventricular block, or rather an atrioventricular nodal block, which is commonly associated with a bradycardia. In other words, it may or may not be present. I've pre-prepared some rhythm strips here for a quick recap. So, a heart block or an AV block is grouped into first degree, second degree type 1 and 2, as well as a third degree heart block. The second degree type 1 is also known as Wenckebach or Mobitz 1. In the second degree type 2, it's also known as Mobitz 2. Don't worry about the eponymous names, but I'm just saying it as you may hear it from clinicians in the hospital settings. So, in a first degree heart block, just a quick recap from medical school, the PR interval, as you can see here, from any part of the strip is relatively constant. And it's going to be more than 0.2, or rather 5 small squares. Now, a second degree type 1, or a Wenckebach or Mobitz 1 heart block, it's going to have a gradually prolonging PR interval. As you can see here, they're getting wider and wider and wider, and then you get a dropped QRS complex. And then the process repeats. With a second degree type 2 or Mobitz 2, you have normal P waves followed by QRS complexes, and then you get sudden drop beats, and they often have a pattern. With a third degree heart block, you can see that the P waves and the QRS complexes are completely independent of each other. So have a look over here. So the P waves are completely independent, and they often have the same duration between them. In other words, the same number of small squares in between them. Similarly, the QRS complexes also have an equidistance between them. Because there's an absolute failure of conduction through the AV node, either a junctional or a ventricular rhythm kicks in. In this case, it's probably going to be ventricular rather than junctional, as the QRS complex is wider than 120 or 0.12, sorry. Or three small squares.